So, good evening, everyone. My name is Dr. J Lakhani, and thank you all for once again joining us for this webinar. This is in collaboration with technocardiology.com. So, all the lectures that we're going to have, it is going to be uploaded on technocardiology.com. Additionally, there'll be additional reading material. There might be some quizzes there as well, and some additional podcasts. Now, we started with some AI podcasts, which have become quite popular, which are actually very good. Some of the topics which we're going to discuss today, especially the NT-proBNP and the other things, echocardiography. If you want a detailed deep dive into it, you can listen to the AI podcast that we have uploaded on the technology.com website. So we have absolute privilege today to have with us our panelist, co-panelist, our expert, a cardiologist, Dr. Milind Phadke. I'm sure he, as Dr. Sami said, needs no introduction, but let me make an attempt to introduce somebody who is very already well known. Dr. Phadke is a professional in the field of cardiology. He's a well-known name in this field. He has a very strong academic record, as you can see from a lot of his publications. Also, I had an opportunity to go through some of his publications as well. He has been a university topper, a gold medalist in major qualifying examinations, including a DM in cardiology, MBBS, MD. He has published more than 40 papers, and he has had more than 10 book chapters. He's a teacher. He's a recognized teacher in the DM cardiology field, an expert in echocardiography. We are going to take his expertise today in his echo expertise. Dr. Milind Phadke, warm welcome to you. Thank you. Thank you for sparing your time, valuable time for this. Thank you for joining for this. And it's going to be an enjoyable session. It's going to be something which, I'm looking forward to learning a lot from you. Welcome, sir.
Mutually.
As a lot of, and Dr. Milind, this is what we do. The idea of the entire thing is that we tend to, when knowledge is something which is gained better when you are in a relaxed state, where you are at home, you have time to listen. Sometimes you're not able to grasp too much in a lot of conferences when the things are actually very fast, we are very short of time. So this is a leisure, long discussion on, and the entire heart failure thing, we're divided into 4 parts. The participants will get a whole bird's eye view of the entire heart failure spectrum as we know in 2025. That's the whole idea. And also, it gives an opportunity for a cross-specialty talk, which are always wonderful. As we learned, we had sessions earlier with other cardiologists, nephrologists, and what we really realized that we need to talk more often. That is something which we realized because there are a lot of things which we learn from each other, and that really helps in our own progress as clinicians as well. So today we are going to discuss, as you all know, about diagnosis of heart failure. And let me first introduce a spectrum in which you can understand the whole way in which you can make a diagnosis of heart failure. And this is relevant to 2025, right? This is relevant to what is applicable now. And then we'll take Dr. Milind's view on the same as well. We all, our bread and butter in MBBS has been, a lot of it comes from our knowledge of cardiology. We all learn about the cardiac cycle when we're in physiology. We all learn about the various drugs in pharmacology, and cardiology is a very important area for anybody who is trained in MD medicine. And we all have seen and learned about heart failure. Heart failure used to be very important cases in your exams as well. So there are certain low specificity, high sensitivity findings to diagnose heart failure. Obviously, dyspnea on exertion is a very important symptom of heart failure, fatigue, weight gain. And in the last session, Dr. Prabhakar told us that a lot of patients with heart failure actually don't get diagnosed at the right time. And that is a major problem because now you have a lot of drugs available where you can give them at an early stage and change the course. Peripheral edema does come into attention of a lot of doctors. Patients often complain of edema, and then that becomes directly correlated with heart failure. So that's one thing which is, again, high sensitivity and age more than 60. An elderly patient is more likely to have heart failure. And if you go to something which is intermediate specificity and intermediate sensitivity, you have the signs of left heart failure, that is crepitations. Again, one good use of stethoscope. On chest X-ray, you'll find cardiomegaly, you'll find pleural effusion. On ECG, you'll find the classical signs of heart failure, the LV enlargement, the hypertrophy. You might find some Q waves with the pyrostria. The tests which are now becoming, we're going to discuss in more detail with Dr. Milind as well, is the NT-proBNP and BNP, which have become very important markers for heart failure. Of course, patient would have often a history of coronary artery disease. Patient may have valvular heart disease, and on an echo, you would find the LA atrial index, EA ratio, and so these are all parameters which we'll be discussing as we go along, right? And then you have high specificity and low sensitivity findings. These are again very specific to heart failure. So patient coming with orthopnea and paroxysmal nocturnal dyspnea, PND, classical signs of left ventricular failure, We'll have the third heart sound, which is also known as cardiologist, cardiology teacher's heart sound, which would be cardiology teacher in cardiology can hear. So again, high specificity. You'll have signs of pulmonary edema on a chest X-ray, very high NT-proBNP levels. Patient might have signs of rigor or a stenosis. And on echo, you'll find left ventricular failure with EF less than 30, which is ref, and you might find some other signs of heart failure on echo as well. Dr. Milind, sir, let's start with this. How do you typically, what are the clinical pearls as far as diagnosis of heart failure is concerned, which are very important, which clinicians, everybody who is practicing should know and should be aware and should keep their eyes and ears open in their clinics?
As you very rightly said in the beginning, the most important thing in diagnosing heart failure is to suspect it. And unfortunately, we have always, our clinical teaching has emphasized diagnosis of heart failure at a very late stage, when the patient has frank florid congestion or hypoperfusion. So it's very important for us to pick up patients who are at risk of heart failure, the stage B in the ACC-HE classification. And as you, many of us in an OPD practice are following up these patients for years. And a time will come when these patients are going to transition some of them into heart failure. So this continuous spectrum of just having risk factors, being at risk for heart failure, and then developing heart failure should be recognized. In a hospital setting, it's of course different. In a hospital setting, patients come with florid heart failure or they come with dyspnea. Then we go to NT-proBNP and all those things to differentiate. We have echocardiography, we have troponins, we have investigations. Even then, heart failure can pose a challenge. The other thing in heart failure is to recognize how important HIF-PEF is. Because intuitively, it's very easy to understand that HIF-REF, yes, the ejection fraction is less than 35 or 30%. Patient is presenting with dyspnea. It's not difficult to suspect heart failure. But it's much more difficult to suspect heart failure with an obese elderly lady who is a diabetic and who's come with persistent dyspnea and the echo has reported a normal EF. Now, in these patients, why would one suspect heart failure? We just attribute it to obesity, deconditioning, but many of them are just walking around HFpEF. So either you do filling pressures in them or you do a diastolic stress test and they turn out to have crossed erased filling pressures. So suspicion, recognizing the fact that patients should be picked up early and knowing that HFpEF is a very important component, especially in older patients, I think is the key today to properly diagnosing heart.
Right, sir. So very rightly said. So let me summarize in a way. You said the florid heart failure, I think anybody will recognize. These are very classical. Again, this is part of basic teaching of medicine. You would, in fact, your instinct also, you practice long enough, your instinctively, you will say that this patient has heart failure. These are very obvious clinical signs of a florid heart failure. But I think it's a subtle symptoms and the early heart failure and the ref, or a PEP, which is more difficult to diagnose. And now it's more important that you diagnose HFpEF because a lot of our audience, a lot of the patients who come to them, a diabetic patient, an obese patient, they are the patients who actually have HFpEF and who have more subtle signs, right? It just maybe just comes with a dyspnea, maybe just comes with a fatigue, which is unexplained. So I think these are all a subtle sign. I think it's very important that we keep again our eyes and ears open. And I think all the more important that now you have therapies which are potentially available for heart failure with preserved ejection fraction. And in that sense, it is very important that we don't miss out on those diagnoses so that the patient is given the right therapeutic treatment at the right time. Let's first deal with NT-proBNP. Yet before that, let me step back once. And we have actually not included that because I'd like to have your views on that. There are a lot of the screening questionnaires and scoring systems. How much value do you really, because most of us are busy practitioners, we see many patients a day. We often don't have time for our patients to really fill up questionnaires or do scoring systems. Do you use any scoring system in your practice and do you find that valuable? And if somebody has the time and patience to do it, which scoring system would you suggest?
No, see, there are many scoring systems. Let me be frank, 99% of cardiologists even are not going to be using scoring systems in their day-to-day practice.
Right.
It's more in the setting of clinical trials or when you are running a dedicated heart failure clinic and you're seeing about 5 or 10 patients daily. That's when you use them. But
Right.
yes, if you want to be more objective, if you want to assess the impact of a therapy, that is the time when these scoring systems really come into play. So I think it's good old clinical judgment combined with appropriate use of biomarkers and echo, which I think is the key to heart failure diagnosis. Let me put it that.
So clinical suspicion, biomarkers, echo, right? So these are three ABC of heart failure diagnosis. So let's start with E. Of course, we did look at some clinical evidences. But let's now look at dwell deep into NT-proBNP. Now, couple of things we'll just need to clarify. So there are a lot of confusion about NT-proBNP. So there are three things will summarize in a sense, which are common misconceptions about NT-pro. So first of all, and last time actually we made this error, Dr. Prabhakar talked about BNP cutoff, and we presumed that as NT-proBNP. I think I went back to the recording and realized that there was a mistake there. So again, for those who listened, I think there was a little bit of confusion there. I'll come to this point in a minute. But again, when you're talking about cutoffs, make sure that you're talking about NT-proBNP and BNPs because both have different cutoffs. So that's something you should keep in mind. Again, NT-proBNP is a high negative. So I think this is a very important point, right? It is a very high negative predictive value. So basically, it's more important to rule out heart failure. So it's the primary use case is to rule out heart failure. And I think that's the essential use case for NT-proBNP. Again, very important to understand that context is very important, right? So NT-proBNP cutoffs have to be dependent on the context of the patient, whether the patient is acute versus ambulatory, the age of the patient, and the renal function of the patient. So these are the important caveats. So when you are, again, interpreting NT-proBNP, it's not one size fits all. You need to look at the whole picture and then decide whether the patient follows a particular cutoff. Sir, in your practice, do you still use BNP or is NT-proBNP or
No,
bio?
almost exclusively NT-proBNP.
Okay. And any difference? Is it one cardiologist said that with the increasing use of RNI, actually NT-proBNP becomes more relevant and PNP sort of takes a backseat. Is that really true?
Absolutely. Because you cannot rely on BNP in RNI patients because for the first few weeks they will get BNP elevations actually.
Correct.
Because of the RNA. No, and it's something which we have always used as a biomarker of choice, and that's been NT-proBNP. I've never ever used BNP for all practical purposes. The cost was an issue in the beginning, but I think now with kits available, with costs going down, it is the biomarker to use. It's no more BNP. Yeah.
Absolutely. Which again, for a routine garden variety patient coming to your OPD, or could be a patient's relative as well. Somebody brings a patient along and says that, sir, I also feel tired.
Right.
What kind of patients do you order an NT-pro?
No, see, I would not use it as you said, in a garden variety person with dyspnea. I would use it typically in a person who has some element of structural heart disease. Apart from clinical, suppose I have a patient of valvular heart disease, a patient of, say, moderate mitral regurgitation, or moderate to severe mitral regurgitation I've been following up for years, and the patient has become dyspneic, or a patient with significant left ventricular hypertrophy who has become dyspneic. These are the patients in whom, because they are to develop heart disease, heart failure, there has to be a structural heart problem.
Right.
In patients with a known structural heart problem, albeit mild to moderate or even severe, who are previously stable, if they come in an ambulatory setting with unexplained dyspnea, nothing else to rule it out, I think these are the patients to do BNP. And of course, I'm talking about the ambulatory setting. Yeah.
Fair. And in an emergency setting, so let's say there's a patient called to the ER, comes to the ER, you get a call from ER, and the ECG mainly shows left ventricular hypertrophy with strain pattern, and the patient has probably history of COPD as well. Would NT-proBNP be useful in an acute setting as well, where you're thinking of?
Absolutely. Both to make a diagnosis and later to compare levels and prognosticate. And NT-proBNP, if you take it along with your B lines on the ultrasound in the emergency setting, the two together have a very good predictive value in diagnosing heart failure and differentiating it from respiratory conditions. So very important mark.
Absolutely. So we all remember, like we all done our MD medicine residencies. In the winter nights, you had this elderly patients coming with dyspnea, and I think unfortunately we didn't have NT-proBNPs back then. But it will always be a challenge whether this is a COPD, this is a heart failure, whether it goes to a cardiology, whether it goes to pulmonology, whether it stays in the CCU, those kind of things. So let's now talk about cutoffs. And as we discussed, NT-proBNP is a very high negative predictive value. So it's a very useful test to rule out heart failure. And let's say you're calling an ER setting where you want to differentiate between an heart failure versus a COPD. 300 picogram per ml is a good cutoff value for differentiating an acute heart failure from other conditions. But when you're dealing with an ambulatory patient, and that's why I said the context is very important. So when you're looking at cutoffs, it's very important that you see the patient's context. And at an ambulatory setting, a value of 125 rules out heart failure. And again, this is where the confusion. So I have mentioned this last time, Dr. Prabhakar, I think he said this and somebody asked again, he said this again. He was talking about BNP values, and this comes from one specific STOP-HF trial, where in an ambulatory setting, where the STOP-HF trial looked at the BNP value and not at the NT-proBNP value. And they said the value of BNP less than 50 rules out heart failure in an ambulatory patient. So that's the BNP value and not the NT-proBNP. 125, sir, ambulatory setting. Most guidelines come up with this cutoff as far as the ruling out of heart failure is concerned. The ESC guidelines, the Japanese Heart Failure Society, which is published in 2025, some of the other guidelines, there's a lot of studies. 125, a fair cutoff in an ambulatory setting.
Yeah, it's a fair cutoff.
Okay. And what about ER setting? There's, of course, saying 300 is an ideal setup in an emergency case. Would you use a different cutoff or would you?
No, even the ICON trial, which initially gave us these cutoffs, this was restudied 10 years later. I think it was called ICON Revisited or something like that. And these cutoffs were confirmed. So if ruling in, of course, we need age-dependent cutoffs.
Yeah.
So the 450, 900, 1800 kind of thing that was there for 50, 75 and above 75, that was very much validated even in the follow-up study of ICON, the revisited study.
So for ruling out, these are the fair values which
for ruling in. For ruling out, it would be 300 irrespective.
Yeah, I'm sorry. So ruling in again. So these are the cutoffs which you talked about as far as the higher cutoff is concerned. They confirm the diagnosis of heart failure. So in an acute setting, less than 50, BNP, NT-proBNP value more than 450, 50 to 75 of 900, and more than 75 1800. So keep doubling at these 25 years age gaps. And in ambulatory setting, again, you will be less than 50, 50 to 75, and more than 75. And sir, let me just confirm with you, when you have an NT-proBNP cutoff above, or let's say, suspecting a heart failure based on the NT-proBNP, would the logical next step be to do an echocardiography, or would you then, or maybe something else? What's your usual logical step?
Echo would be mandatory because we need to know so many things from the echo.
Right. So echo gives you much more information. So this NT-proBNP is a good test to do along with the other tests when you're suspecting heart failure, but I think it has to be backed up with an actual visual confirmation with an echocardiography. Right? So that's the thing. Dear audience, I think these are the valid cutoffs which you should probably be looking at. Maybe take a screenshot of this. We'll have, of course, these slides as well in the cardiology.com as well. So you can then have a look at these values and later date as well. Okay. So we talked about context, and context is very important. And there are conditions which actually, I would say false high, but I would say rather give a higher value of NT-proBNP. So patient with a renal dysfunction, patient with CKD, you will consider a higher cutoff value. Atrial fibrillation, again, patient would have a slightly higher NT-proBNP. Advanced age, we already saw that age-based cutoffs are generally there. Females tend to have a slightly higher value. But I think one place where you need to be a caveat, which is going to be very important, especially in today's world when looking at heart failure with preserved ejection fraction, there is a population which is more vulnerable, that is the obese people, right? So in obesity, the cutoffs tend to be lower. So the values tend to be lower in obese people. Any specific cutoffs that you use, or let's say a patient obese, 50-year-old with extreme obesity walks in, is dyspneic. Of course, it could be 100 other reasons for dyspnea. What kind of, I ask for an NT-proBNP and then not really sure of how to interpret it. What kind of cutoff would you consider an obese patient, what's your strategy for them?
Unfortunately, we don't have clear guidelines in obese patients, but we must recognize that a significant minority of them will just not have elevated NT-proBNPs in our cutoffs. So we don't know whether we should be using lower cutoffs for them. That's one. And the second thing is that even smaller elevations in NT-proBNP as compared to non-obese individuals have the same prognostic significance. So if we are not sure, then we would probably do something like a diastolic stress test or measurement of elevated filling pressures, because obesity is a challenge and we really don't know. See, for renal dysfunction, there are various guidelines which have a slightly higher cutoff. For atrial fibrillation, you have the values on the internet. Obesity is a challenge. Yes, we must recognize that suppose a 600 value in a non-obese patient, we would not take it that much if it was stable. Maybe in an obese person with a 600 value with classical symptoms, yes, should ring a bell.
Okay, fair enough. So again, maybe the index of suspicion should be slightly higher. That is what, even with a lower cutoff. So I think that could be a fair.
And we don't know why it happens. Again, that's very.
To fairly say, basically, again, from a physiological perspective, last time we discussed, it's a measure of the stretch of the cardiac, right? So like rightly said, when you have, even in a valvular heart disease, when you're stretched, when you have an MR patient going into failure, you will have the values being up. So I think that's where the importance really comes. Last week, we had breakfast with Dr. Amya Joshi, a close friend of mine. He's been doing a lot of studies on this, and unfortunately, he had sent the slides, but I forgot to incorporate them. He's recently done a study in diabetic patients from India and looked at NT-proBNP cutoffs and again validated the cutoff value of more than 125, which is again equivalent to the value cutoff which we see with the other guidelines also. So again, this has been validated in an Indian cohort of cases as well. Very importantly, trend does matter. So in acute settings, more than 30% reduction of NT-proBNP from admission to discharge is a good sign. So I think, Dr. Milind sir, you said this, your protocol. So when the patient comes to the ER, you measure an NT-proBNP and very, very rightly said, not only is it helpful in diagnosis, but it's also a benchmark which you can then use for, or as a cutoff, as an initial point, which you can then use for prognosticating the patient at the time of discharge. So is that the protocol that you generally follow? And so would you generally do NT-proBNP at discharge again to see where?
Yeah, there may be some financial constraints in some patients, but in an ideal world scenario, it should be done. Both the absolute and the proportional fall in the NT-proBNP does have very important prognostic value, both in the short term and in the intermediate term. And it can help you guide therapy as well, optimized therapy.
There's a study which they did, which they looked at a very simple thing: high cutoff at the time of admission and what cutoff was there at the time of discharge. So obviously, high cutoff at admission and high at discharge, again, you had bad prognosis. You had low value at admission and high value at discharge. Like, you probably should not be discharging this patient, but again, we'll have poor prognosis. The best prognosis were those patients who actually did well. So you had high value at the admission and low value at discharge. That is, these are the patients who actually did very well in terms of the readmission rate, because we all know you see any clinical trial, they talk about heart failure admission, which is a very important clinical parameter to judge a patient's wellness. And you tend to have a high value at discharge correlates with the readmission, which could happen. So in fact, just when we're talking about it, a diabetic patient of ours who's been on a follow-up for a long time, she was discharged a few days back, has heart failure, and just in 2 days got readmitted again. So that's a very typical sign of patients being readmitted again, right? It's a financial burden for the patient as well as for the family and the relative. These are generally elderly people also. There's a lot of problems involved with the care as well because of other things. So I think, again, it's a good sign. The right time to discharge the patient would be when you have a good drop in NT-proBNP. And again, it's a sign of patient's well-being. And again, in an ambulatory setting also, when you are giving guideline-directed medical therapies, a reduction of NT-proBNP really is a good sign. So do you, sir, especially you have diabetic patients coming to you with heart failure, even a HFpEF, do you do serially NT-proBNP in such patients to see how they're doing with the therapies which you're giving? Or, yeah, of course, barring the cost and the other process involved, but do you do a serial monitoring of NT-proBNP for ambulatory patients? I'm sure admission patients, there's no doubt we'll do it, but for ambulatory patients, does it make sense?
In a selected number of patients, yes. Especially, even heart failure, we sometimes do manage on an OPD basis if the patient is an early heart failure. These are the patients at whom we can get a very good idea of whether your therapy is working or not. They've come with an NT-proBNP of say 1200, 1400. You treat the patient, not everybody is willing for hospitalization. Maybe they are not sick enough to hospitalize.
Correct.
Next time they come with reduced symptoms and in addition the NT-proBNP falls, it is a very good marker. And generally when the NT-proBNP falls, the patients clinically do quite well. So it's very good corroboration, yes.
Okay.
In ambulatory.
So again, a good choice to consider. And again, I think now we have so many drugs available for heart failure management. I think again, it makes sense to and would you select, of course, now guidelines say that all the 4 pillars of heart failure management should be given as early as possible. But again, we live in a country where not everybody can afford everything. Some of these medicines are actually quite expensive. Do you, in your practice, also use NT-proBNP for judging which patients would need RNE, which patients would you probably consider carrying the Findinol and so on?
Maybe not for judging a specific choice of therapy, but definitely to judge adequacy of therapy while stepping it up. I think that would be more like it. Because again, we don't really have the choice of therapy which to add first would also partly depend on the clinical status. Whether they were more congested or more hypoperfused when they came, whether the patient had baseline tachycardia or not. These are the decisions. And nowadays the trend is to start everything in small to medium doses and then step it up and maybe within 1.5, 2 months to optimize as quickly as possible. That is what the guidelines say now.
Okay, great. And again, of course, we'll have a specific dedicated section for management of heart failure. But from your perspective, since we are on the topic of optimizing therapy, which of the 4 pillars of the major drugs which are used in heart failure, which do you use first, and then which are the ones you add serially later?
No, as I told you, it depends upon how the patient presented. As a hypoperfused patient or a congested patient, now the guidelines say that you should not stop beta blockers at all. Now, suppose the patient has come with a creatinine of 2.5 or a higher potassium. So those are the patients in which we would be a little wary of RNE or MREs. Or the patient has a little bit of bradycardia. then these are the patients in whom we would start beta blockers a little later. As I said, and
Clinical
as
context.
many as possible, but definitely you may start with diuretics and ARNI to start with. Maybe you would not discontinue beta blockers and try and step up with MRAs and HGT as quickly as possible. But it depends on patient to patient. There's no hard and fast rule, I think.
And are you of the school of thought? So again, there are two schools of thought as far as SGLT2 is concerned. Do you start SGLT2 in your patient while they're admitted before their discharge, or do you generally reserve it after the patient comes back
No,
unconscious?
I do. In some patients, I do start before discharge, especially if they are otherwise doing okay. And there is data to show that even in the trials that starting it before discharge, the curves separate out very early, the benefit curves.
Correct.
So starting it early makes sense.
Okay, fair enough. So I think that's a great point. Again, I think with this we'll discuss a little bit about an ARNI. So again, just be careful. BNP levels can actually increase initially when you're giving ARNI, whereas NT-proBNP is more useful. So again, be very careful if you're using BNP with ARNI, you might have a slight increase with the value. So again, that's something you need to be aware about. So now, so let's move to echocardiography. And again, your area of expertise and specialty. Let's drill a little deeper beyond the usual basics of echo as far as heart failure is concerned. And there are some interesting questions from the audience also. We'll take that along with this. So I think the first step, the left ventricular failure ejection fraction monitoring. And we all know this. We saw this last time as well. Heart failure with reduced ejection fraction is defined as a LVEF of less than 40%. We have mildly reduced ejection fraction, which is 40 to 50%, and PEP, where you have the heart failure with preserved ejection fraction more than 50%. I think there is now a category called improved ejection fraction also. So of course, these are the primary way in which you classify heart failure based on the ejection fraction. So your views on measuring ejection fraction. We also know, I think last time Dr. Prabhakar told us something very interesting. There are echocardiography, there are echocardiography, right? So there are expert echocardiography where you have so much information you get just from echo. And then there are times where lazily done echocardiography just gives you a rough picture. You have those reports which are pre-printed, diastolic dysfunction and this and that, which probably mean very little. So again, what's your view on echo? And secondly, the ejection fraction measurement and its correlation with clinical practice.
I can't overemphasize the importance of a good echo both for HFpEF and for HFrEF because it's a complete window into the heart. Apart from ejection fraction, it will give you filling pressures, it will give you tricuspid regurgitation, the pulmonary artery pressures, it will give you an idea of the LA function, the IVC congestion, so many things, and even in HFpEF also. And it will give very valuable clues about the etiology of the condition you're dealing. So it's so common for hypertrophic cardiomyopathies to be missed. It's so common for subtle regional wall motion abnormalities not to be picked up. It's so common for aortic stenosis to be missed in a patient with NV dysfunction. They are labeled as dilated cardiomyopathies, where in fact they have aortic stenosis, low flow, low gradient aortic stenosis. So if you do not do an echo properly in a patient and just give a garden variety kind of printed report, as you said, you're doing a big injustice. If you're not really an expert in doing echoes for heart failure patients, you shouldn't be doing it. And then send them to somebody, get it done, and then treat the patient.
Absolutely. So I think very useful. I think the quintessential investigation, I think we'll do one echo is something which is a well done echo by an expert is it's completely going to change the treatment spectrum for the patient. There is something called a GLS, sir. And again, we are now delving deeper into some of the newer modalities which are now being used for echo. GLS is something global longitudinal strain, the GLS. Can you tell us more about GLS and do you use it in practice at all? And again, I am sure understanding that a lot of these things are actually new, experimental also, and probably you don't even have the time to do in all these patients. But again, from a theoretical angle as well, what exactly is GLS and where does it really fit into the echo spectrum?
As the geometry of the left ventricle is such that it has 3 layers of fibers. And these fibers with the cardiac cycle, depending upon whether they are longitudinal, circumferential, or spiral, they have varying degrees of movement. And what GLS does is that the deformation which is caused by the contraction of these fibers is measured. More the contraction, so it's basically the change in length of the fiber. So the initial length minus the later length, or final minus later. So shortening is what happens during contraction. So more the shortening, better is the fiber health. So GLS is basically a negative value. So more negative is the GLS, more normal it is. So classically for the left ventricle, now the GLSL stands for longitudinal. So the most commonly measured index is the longitudinal shortening of the ventricular fibers by a method known as spectral tracking echocardiography. And what is done is every segment, there are 17 segments in the ventricle. So the strain is measured in each individual segment in 3 views of the echo. And then the machine gives you a complete value, which is the average of all of these on a bullseye plot. So the average value, if it is more negative than minus 18, or you can say less than minus 18 or minus 17, that is considered normal. The more abnormally ventricular health, the lesser the contractility of fibers, the more the value becomes positive. So minus 16, minus 15, minus 14, these are positive values. And the biggest role is in picking up early systolic dysfunction, because in frank LV dysfunction, when the ejection fraction is down, obviously the GLS is going to be down. But to give you some practical examples, I'll give an extreme example. For example, in children with thalassemia who are on transfusion therapy, and we want to diagnose iron overload. MRI is one way, but GLS is a cheaper way, and there is some correlation. If you do GLS serially and the GLS reduces, it may indicate early systolic dysfunction. Similarly, even in HFpEF patients, it's been found that, as you said, EF is a crude way of distinguishing between or phenotyping heart failure. Many patients in whom the EF has been labeled normal, if you do their GLSs, they have reduced GLS. So second ventricular function may go down. Then even in constrictive pericarditis and restrictive cardiomyopathy, we have ways of, from the strain of knowing which is which. But the fibers that are affected are different. So all in all, for early diagnosis of systolic heart failure, GLS is a very good option. And it's now being studied everywhere, whether it's muscle disease, valvular heart disease, is early ischemic heart disease, cardiomyopathies. It's a very good mark. Yes.
Very interesting, very interesting. So again, just so if you want to decategorize your patient, from what I understand, a HFpEF patient on a crude echo with a sort of a rough estimate of the ejection fraction. But if you do a GLS, you might actually find some early systolic, and that could again reprognosticate the patient in terms of the potential diagnosis. And one other very interesting use case you said is thalassemia patients on transfusion, and you want to see the effect on the cardiac muscles. I think that
Effect on the myocardium, yeah. I don't know.
So I think that's a very interesting areas. And I think one thing which, again, we also used to learn when we are in MD medicine, there is an important role of left atrium in overall heart failure assessment. Again, from the ECG also, it's an important area. So why is LA so important? How do you use it in your heart failure diagnosis?
I mean, LA is the chamber which is directly linked to the lungs. So whatever happens to the LA will immediately be reflected back into the lungs. And it is also the chamber which receives everything from the ventricle whenever it is directly connected. So any ventricular dysfunction, systolic or diastolic, is going to affect the LA. And sometimes the same disease process may affect both. Now, in fact, we are also recognizing atrial cardiomyopathy. Okay. Primarily caused by mitral regurgitation. So if you look at the indices, the most important thing in the LA is the LA volume. And I think you've mentioned it ahead, but if you have an LA, so if you have an LA volume of more than 34 ml per meter square, it's one of the 3 important criteria in the diagnosis of HFpEF. And even in HFrEF, as HFrEF starts becoming more and more advanced, then the LA starts dilating. There are many other conditions, say a restrictive cardiomyopathy. So biatrial enlargement is the hallmark of restrictive cardiomyopathy. In chronic mitral regurgitation, one of the ways in which we realize that this MR is severe and chronic is a dilated LA. And it's the status of the LA which will tell you how the pulmonary circulation is going to behave. So long-standing chronic severe MR or voluminous LA which has undergone wall hypertrophy, the pulmonary circulation is well protected. An acute MR, the LA cannot adapt suddenly. Pulmonary pressures, the wedge pressures go up, the patient goes into pulmonary edema. So in addition, the booster pump function of the LA. So about 25% of the ventricular filling is contributed to by the LA by its contraction in the pre-systolic period. Now, if the ventricle is hypertrophied, for example, in aortic stenosis or in hypertrophic cardiomyopathy, because the ventricle cannot fill normally in early diastole, the importance of the LA in boosting the pumping of the ventricle is even more. So it may contribute 35 or 40%. So if these patients go into atrial fibrillation, they go quickly into hypotension and heart failure. So the LA is a neglected chamber, but let me tell you, it's a very important chamber.
Right. Very important. So I think very interesting. And like you rightly said, LAVI, more than 34, is now an important clinical criteria for HFpEF diagnosis also. So
I went into a bit of details. I hope that was okay.
Yes, no, that perfect, sir. It's beautiful. I think, yeah. So thank you so much for that. And then LH train, can you tell us more about what is exactly LH train and what's the use case there?
So again, like we do for the LV, we can calculate the LA strains. Not all machines have dedicated software, but we usually use the LV software and calculate the LA strain. And again, it gives you an idea about the intrinsic LA function. So, apart from LA size in diastolic dysfunction or in certain cardiomyopathies, it will give you a good idea of how the LA is behaving. It's especially in the diagnosis of HFpEF, LA strain is now assuming a lot of importance.
Okay, great. So I think they look at it more carefully. I think that's something
There is a
we should
lot.
mention. Yeah. Okay. And when we're dealing with heart failure, we are also dealing with the right heart failure, right? So I think the assessment of right ventricle, and I understand that's a big challenge in echocardiography that's often missed out. I'm sure even a sort of an amateur and early echocardiographer will do a good job as far as the LV is concerned. But it's the right ventricle which requires a more level of expertise and understanding. How do we do a right ventricular assessment? TAPSI is a way. Can you tell us more about the right ventricular assessment in heart failure?
Uh, and later I'll also provide a link. I have a YouTube video exclusively dedicated to right heart failure, right ventricular failure. The right ventricle anatomically is different from the left ventricle. Unlike the left ventricle, which has a contractility of a ringing motion, the right ventricle is more like a peristaltic motion. So
Right.
not all parts of the right ventricle contract together. Secondly, the shape of the right ventricle is very odd. It wraps around the left ventricle. So geometric assumptions like we do in the left ventricle for ejection fraction are not very easy.
Okay.
Third, the most common measurement that we use and even I use is TAPSI. So TAPSI only gives you an idea of the longitudinal motion of the of the RV. So sometimes in some patients in whom the longitudinal motion is not affected much, sometimes you can miss out RV dysfunction. So when I look at the RV, first I look at the RV size. And it's important not only to look at the RV size in four chamber, but also to look at RV outflow carefully. There are conditions in which the RV outflow in parasternal short axis may dilate more. Secondly, of course, is the RV volume. Third, even RV strain we are increasingly doing. Though we don't have dedicated software, we use the LV software for the RV strain. So RV strain again is an early marker.
Right.
Then the tissue Doppler, which tells us the S dash and the lateral tricuspid annulus. That is again a good marker. And 3D, again, I didn't mention it for the LB, but 3D again is becoming very important in assessing RV function. And it's very important. There are some cardiomyopathies which may involve only the RV, or there are certain pulmonary hypertension or pulmonary stenosis in which the RV is the ventricle which is going to be affected. So if you don't assess the RV, you're not doing a complete echocardio. And TAPSI is not enough. So all these things have to be put together when you assess the RV.
So it's a multi-pronged approach to really
Yes.
assess the RV. And
Fraction
TAPSI is just one. Yeah,
Yeah.
it's just one objective marker, but I think you need to look at
But
the
yeah, it's a good ballpark kind of thing. And just give you
Yeah.
an example. Yesterday, I was doing an echo of a patient who had a large atrial septal defect and severe pulmonary hypertension, Eisenmenger syndrome.
Okay.
Now, this patient obviously to me had reduced RV contractility on the echo. I could
Right.
see that the RV free wall and the septum were not coming together. But if you looked at the TAPSI was very fine. The longitudinal motion was excellent. Patient was showing signs of early congestion. So in these kind of patients, we have a problem.
Right.
Just to give you a perspective.
Excellent, sir. Excellent. I think that's a very useful test. And then think about IVC, right? So again, as we now understand more about heart failure and we're more deep into it, we understand that IVC assessment is also something which is quite critical. Often, again, we don't see them in conventional echo reporting. So I think that's something which is again now emerging as a very important area. Can we tell you more about IVC assessments in an echo?
And the only thing I should say is it should be done.
Right, sir.
Listen. No,
Absolutely.
and the other thing is ki the IVC is mostly reliable, but sometimes in right heart pathology, for example, if you have severe tricuspid regurgitation or if you have very bad RV dysfunction, then the RVC may be congested primarily because of that. So that
Right.
is one caveat you have to keep in mind. But for, say, a biventricular failure or a left heart failure where you're assessing the pilling status, it's quite a decent mark. There are problems, but it's a decent, good screening mark.
Okay. So it should be done. That's
It should
the
be done.
take-home
Yeah.
message. It should be done. That's I think.
So we were trained in DL to start with the IVC. The echo should start with the IVC. It was like that.
And I think, of course, just a few, again, calls for the physicians there. Thick walls, of course, left ventricular hypertrophy is something we would need to see in chronic hypertension. But again, these are something which a physician would experience more commonly. And epical sparing is a feature of cardiac amyloidosis. Again, that's a very rare condition, but again, you could sometimes be useful. And again, echo can be very useful for tracking therapy in your patients also, especially well done. And there's a question from the audience. Avijit has asked, Isa, what are the methods that we use for EF calculation in echo? Of course, most of the time it's a visual assessment. It's a more of a rough, looks like 50%, looks like 60%, those kind of things. But what's an objective assessment of
Probably Tychoids and visual are the methods we
Yeah.
do most commonly. And sometimes in a research setting, a 3D would be probably the ideal.
probably a better? Fine. Okay, fair enough. So I think thank you for that. So that was about echocardiography. Again, friends, if you have a question, please post them in the chat, and I think we can take that as we have Dr. Milind sir with us today. So again, to summary about newer age findings, I think LA index is something which is important, especially for FPEF. And again, there are other FPEF markers also. We probably reserve it for the dedicated section in future. Again, LVEF less than 30% is very important in diastolic volume dimension. Inferior vena cava more than 1.2 centimeter collapse during a slip, less than 50%, but again, not commonly an exercise. That's something which we should be looking at in future. Let's then look at other imaging modalities, some newer imaging modalities which we use.
So, quick points because the other imaging modalities probably I'm not an expert, but 2 points about echo, if I can quickly make.
Yes, absolutely. Please.
One, in HFpEF, one must understand that sometimes you may not get clear and objective evidence of raised LV filling pressures at rest. So you have a very breathless patient, you know this patient is in HFpEF, you do a baseline echocardiogram, the diastolic function is fine. Do subject these patients to what is known as a diastolic stress test. So make them exercise. It's done in a proper protocol. It's done at some centers, and you will get a significant number of these patients who have provocable rise in the LV filling pressures. And now the guidelines mention either resting or provocable rise in the filling pressures as a diagnostic criteria for heart failure. That's one. Otherwise, you will miss many HFpEF diagnoses. And the second thing is when we are in MBBS, you were talking about amyloid was considered like a failing kind of thing. Why do you want to talk about something that is so rare? But now we are seeing a lot of amyloid. In fact, let me tell you, in elderly people with HFpEF above the age of 60 or 65 years, up to 15 to 20% can have transthyretin amyloid. Similarly, a patient with aortic stenosis presenting with heart failure above 65, 20 or 25% can have transthyretin amyloid. And amyloid indicates a poor prognosis in these patients. So even if you treat the aortic stenosis, their heart failure may not improve. Amyloid is something now that in the last 5 years, we are becoming much more aware. And for some forms of amyloid, now there are therapies available. So it is now an important condition.
It is. Right. So very rightly said. So I think it's again an emerging area which we see this diagnosis much more common now with the improvements in echocardiography, improvements in the other diagnostic modalities which you're going to see. So other imaging tools, I often see our cardiologists often asking for cardiac MRIs and other things. Again, before we dwell into these individual topics in a slight detail, where do you really use other imaging modalities if you're going to use in your practice? What are the tools what are the other gadgets, slightly fancier ones that you tend to use in your practice?
Yeah, being in Mumbai, we have the luxury of everything being available. But I use a lot of cardiac MRI. Unfortunately, we have limited expertise for MRI. And unlike in the West here, the cardiologists don't see and interpret cardiac MRIs mostly. It's been left to the radiologists. I am also guilty, but we should take more of an interest in MRI because, see, for myocardial viability, for cardiomyopathies, for some forms of valvular heart disease, for some forms of congenital heart disease, MRI is an extremely important tool. In fact, in viability assessment, MRI is considered the gold standard. You weigh everything against an MRI. So similarly, in hypertrophic cardiomyopathy, to prognosticate, to know the degree of fibrosis, the tissue characterization that you get from an MRI, you will not get from an echo. Amyloidosis, you can suspect it from an echo, but it's an MRI which really shows the failure to null, So tissue characterization, nothing beats an MRI. So I think of all these investigations, the one which we use most is an MRI. The others we use, but not so much in heart failure. We'll go to them one by one. Maybe.
Right. So I think it's a great point. In fact, so again, young cardiologists or young potential cardiologists listening to this, I think probably look at cardiac MRI as an area of subspecialty knowledge, because I think it's a very important area. And like sir very rightly said, some of these things actually fall in between two specialties. So again, radiologists often want cardiologists input, and cardiologists are also not that trained in cardiac MRI because it has emerged relatively recently. So I think this is an area where again, young cardiologists maybe should be looking at as an area of emerging expertise, and maybe consider a little bit subspecializing in this also. Cardiac MRI or CMR imaging, very important, very rightly said, it's superior to echocardiography. So it's now, and now with easy availability also. So because it used to be a problem, but now again, the cost is coming down, the availability is there. And like you said, in Mumbai, for that matter, the Ahmedabad,
Very
most of
expertise. That's right.
yeah, so you have this available everywhere, and you can see. And there's something called a late gadolinium enhancement, LGE, which again, so basically, sir, and correct me if I'm wrong. What they say is that basically you look at the gadolinium enhancement, and then you look at the late phase of and a normal tissue. So basically, gadolinium will take up in, especially disease tissue, you will find a particular pattern of the gadolinium enhancement, which is again characteristic of a lot of disease. For example, if you have ischemia, you have a typical subendocardial LGE, which you'll see. In a sarcoidosis, you'll find a typical patchy multifocal pattern. So I think a late LGE pattern is something which is useful for characterizing your heart failure patient. Am I correct? And
Absolutely. And if it's in a coronary territory, it's more likely to indicate ischemic cardiomyopathy. So it can help you distinguish between ischemic and non-ischemic cardiomyopathy. Like you have said in sarcoid, it has a very typical basal septal and lateral wall pattern with the mid and epicardial patchy pattern and hypertrophic cardiomyopathy. For example, if you have fibrosis, see the landmark, the real problem in hypertrophic cardiomyopathy, apart from the obstruction, is the myocardial disarray. And there is increasing fibrosis as the disease becomes severe. And this
Right.
is something which echo cannot diagnose. So if you have more than 15 to 20% fibrosis, in the long run, it suggests a slightly higher arrhythmic risk. So gradually now that is also being incorporated into guidelines. So amyloidosis again.
Right.
Uh,
That's an
failure-
important
yeah,
use
so-
case for cardiac MRI. So, yeah. Right. So I think it's again, very emerging, important area. Then there's something called a parametric mapping. So you have again T2 mapping, and there are again software applications for this also. Again, an emerging area where, again, a pattern would be useful for. So these are all nuances of cardiac MRI.
we are also learning them.
Yeah. So I think future, that's again, it's a future of cardiology also in a sense, because you have all these newer tools available quite uniquely. And then of course you have nuclear imaging in heart failure. Again, it has its ins and outs. We had some cardiologists really asking for a lot of nuclear imaging in heart diseases. But I think again, it's an area where, again, it's a little bit of mixed bag as far as the use is concerned. It's a wide spectrum in amyloidosis. And I think, sir, this is which we have seen that the tracer that you use for bone scan, right? The MDP, technetium 99 MDP, is actually very specific. We found again serendipitously that it's a very specific marker for cardiac amyloidosis. So I think that's where one place where nuclear imaging could be useful. And like you said,
Specifically, it helps you distinguish between ATTR and AL. So if you do a technetium pyrophosphate scan and you have grades of uptake, so if you have grade 2 or grade 3 uptake, and your serum tests for immunofixation for light chains are negative, then that's very, because see, apart from a biopsy, there has to be nothing to really distinguish between AL and ATTR. So if you have a grade 3 uptake in a technetium pyrophosphate scan and your light chain assays are negative, then that's almost conclusive evidence of ATTR amyloidosis. Then you don't have to do a endomyocardial biopsy. So you're very right. In amyloidosis, to distinguish between the two types, it's very important. And of course, the second place where we use it is in assessment of viability.
And where else do you use a nuclear imaging? Viral myocarditis, I've seen people asking for FPG PETs. Is there any kind of, during COVID time, there used to be a lot of hue and cry about viral myocarditis being an important problem and cause of death also. Where else do you use nuclear imaging?
No, I have, for myocarditis, I have mainly used MRI and we mostly use CMRI. But for viability assessment, for detection of ischemia, inducible ischemia, and for amyloid, these are the three places where 99% of our use would be this.
Fair enough. So again, just for the audience, we are looking at now a spectrum where you already had a patient, you established the patient has heart failure. But you are now looking at certain subtleties in terms of the potential diagnosis of heart failure, which is again in clinical practice very relevant because the therapies may also differ in some of these conditions, and you might consider different treatment also. Of course, CT, coronary CT angio, very important, especially diabetic patients, also a useful test for, again, not directly a heart failure assessment, but again, etiology of heart failure is very good. So where do you use generally CCTA in your practice again?
It's a very good non-invasive rule out tool. As you said,
Right.
you have very correctly mentioned it. It has a very high negative predictive value. So one example, as you gave, is in a diabetic individual. Or now, so many people with diabetes have envious systolic dysfunction, and they don't turn out to have anything in the coronaries. We do a coronary angio. So in these kind of patients, as a rule in, a rule out, it is very useful. rule in there are problems. Still, we get CT scans which show 90% coronary lesions. We do an angio and they're not even 30%. But CT is improving. CT is getting incorporated with FFR and things like that. I think CT is the modality of the future. Even moving apart from heart failure, yes, it's very exciting.
But as of now, you very rightly said it's a negative predictive value again. So rule out and don't use it to rule in. So again, that's
it should not be the only.
Not the only. So you again useful place you to know when to refer to a cardiologist definitively. Because this you need to see a cardiologist because again patients often sometimes delay and that's a problem. So I think that's a good starting point again, especially for your patients who are a little resistant of these things. So I think that's the end of it. And I will just summarize this, but a few things which I learned, I think beautiful things. And to start from back again, CCTAs are very useful as a rule out marker for especially your diabetic patients where again the patient may have most little signs, and these are high-risk patients who might have a coronary event if not picked up. Again, cardiac amyloidosis is an emerging area. Again, a lot of people are not aware that it's much more common, especially in older patients. You are seeing more of that in practice, and again, that's something which is useful. Again, cardiac MRI, something which especially the LGE patterns are very useful for sub-classifying the cause, etiology of heart failure. And you talked about HFpEF, the importance of LA in HFpEF, the importance of especially your patients, you're thinking this patient is HFpEF, but then the echo is not showing the typical features, make them exercise and then retest. So I think that's a very useful practice as well. And I think we going back again, we are NT-proBNP. And again, a very important negative predictive value for ruling out heart failure. And values of 300 in acute setting, but 125 in an ambulatory setting, especially in a lot of the diabetic patients, would be a useful cutoff to consider for further evaluation. Remember, I think one thing very importantly that everything has to be taken into the entire context. It cannot be individual, so it cannot be just based on NT-proBNP, not just based on a CTCA. You probably need to look at the whole picture to really make the complete diagnosis and give the therapeutic treatment. So your take-home learning points for our audience, something they should not miss out.
So we have broken down the whole 1 hour session very well into clinical biomarkers, echo, and neuroimaging modalities. And as everybody must have realized, each has its place. In fact, I was going to post a JICC article from 2018 just on the clinical examination in heart failure. So all the signs that we have, which are prognostically important, which really tell you whether the left heart or the right heart pressures have increased, which are less specific and sensitive. So what we were taught in MBBS days, just a list of signs of heart failure, that and actually which of them are useful in clinical practice is different. Secondly, even NT-proBNP. Now, NT-proBNP, when put in its perspective and when assessed and when used properly, is an excellent tool for diagnosis and prognostication. Echo, in one word, if you have to have a complete echo from a well-trained echocardiographer, it will give you so much information. It will make subsequent management of life very easy. And in most cases, you will not need the step 4 investigations. But when they are needed, use them, especially cardiac MRI. And we need more expertise of cardiac. That's what.
Absolutely. Yeah. Very well said, sir. I think Avijit has asked a question, I think, about heart failure management. Dr. Avijit will discuss this in the fourth part in more detail. And Majumdar has raised his hand. Let's just allow one question. Dr. Prana, please go ahead and ask the question. Pranab, you are there? Okay. Dr. Samir, any words from you?
Yeah. So I think it was a great session as always. In heart failure, always a challenging diagnosis. From the clinical perspective, we have very common investigations like NT-proBNP, 2D echo. But today, what I guess was very interesting was the concept of LA strain, global longitudinal strain, TAPC, the IVC measurement, something which is not used very frequently in a day-to-day diagnosis. And I think that was really informative from the treating physician point of view. So thank you very much to Dr. Om and Dr. Milind Phadke for an excellent discussion, I would say. Dr. Om has always been great in coming out with a non-didactic, but a discussion mode of session. And I think that's where less text, less slides, but more of retained knowledge is actually the way to go ahead.
It's a very good format. I congratulate you on this one.
Thank you, sir. Thank you, sir. And thank you so much for, I think there was just a great academic using there. I think it's a great learning experience. Wonderful, sir. I think a lot of new things to learn. And,
We keep learning from each other, I think.
so
Every
that-
time we
that's-
interact, we learn from each other.
that's the best way. That's the best way, I think. So thank you so much, sir. Thank you so much for being part of this. I think it was a great session. I think
It was my privilege.
and
Right.
I'm sure the audience thoroughly enjoyed it, learned a lot. I certainly learned a lot. So thank you so much, sir. I'm sure your students are blessed to have a teacher like you. They'll be. Thank you so much. And I think,
Dr.
yeah,
Permit
yes.
me, can I just share
Yes.
one slide?
Yes.
Since it is a series of 4 webinars, I just want to project one slide. And
Sure.
if you can confirm, is the slide visible?
Yes, sir.
Okay.
Yeah.
So before we part for the day, this is just next session is slated on 26th of June. Again, Dr. Om Lakhani would be handling the endocrinology component of the Sweet Beat program, webinar 3, where we'll be focusing on HFpEF. And Dr. Arindam Pandey, cardiologist from Kolkata, would be orating on the cardiology aspect. So do join us next Thursday, the same time, and we'll carry forward our learning on the third webinar. And thank you very much, and good evening, and have a great day.
Thank you so much.
Thank you so much.
Thank you, Milind, sir. Thank you again.
Bye-bye.
And good night to everyone. And see you
Good
for the
night.
next program. Where we'll discuss in depth about it. So
Thank you, sir.
Bye. Thanks a lot. Thanks a lot. Bye. Bye.
Bye.